Dear colleagues, a very good day. Did you ever consider to use a nociception monitor? If so, then I congratulate you with your innovative approach in your clinical practice. If not, I hope to convince you in the next 10 minutes of some reasons why you at least should consider to use a nociception monitor from time to time. These are my conflicts of interest. There are different strategies to quantify the balance between nociception and anti-nociception, and the majority still use the balance between auto and parasympathetic nerve system, such as the skin conductancy, surgical pleth index, the ANI, and the nociception level index. There are alternatives like QNOX and cortical input who use EEG, and some use brainstem or spinal cord reflexes such as the pupillometry pain index or the nociception reflex threshold. And there are even some that use pharmacological endpoints to predict the probability that a patient moves at a certain time. Of course, all these different mechanisms will lead to different performance, and we need to look for validation studies on different endpoints for each monitor separately. Don't extrapolate the results from one to another. Let us first have a look at the risk factors for chronic pain. Some of the known risk factors are patient-related, such as psychological factors of the patient, and some are surgery related, like the longer duration of surgery or the occurrence of complications like nerve lacerations. Those have a consistent strong evidence to correlate with chronic pain, and that's consistent evidence between studies. The anesthesia related risk factors, like the use of general versus regional anesthesia or the amount of opioids used during surgery, have more mixed or low evidence quality. One of the factors that is consistently found in risk factors is the quality of the pain, where a patient who has preoperative existing pain or uses a lot of opioids, or a patient has severe postoperative pain in the immediate post-op phase or during the first 5 days of surgery, after surgery, these are strongly correlated with the occurrence of chronic pain. And there the NAN monitors might play a role. They might have an effect on the suppression of the humoral stress response and avoid all kinds of chronic inflammation effects that are the consequence of it. They might reduce excessive amounts of opioids and so avoid the induction of hypersensitivity. They may have an effect on the avoidance of patients that have severe pain in the immediate post-op phase. And then we have to check in studies whether there's a reduction in incidence of chronic pain. What is found in the literature? First, let's have a look at the acute pain. In this example study, using nociception level monitor to titrate remifentanil, it's shown that there's a 20 to 30% reduction in the cumulative amount of remifentanil given throughout surgery, and this has an advantageous effect on the risk of hypotension and the severity of hypotension during the surgery. And despite the fact that we reduce remifentanil with 30%, there's no significant difference between the pain scores in the control group versus the null-guided group. Of course, this is because the scores are relatively low in both groups, and that is because in this study there was an effective strategy to cope with postoperative pain, being 1 gram of paracetamol and a sufficient dose timely administered of morphine. If you use another drug, titrate fentanyl according to null, then there was no big difference in the cumulative amount of fentanyl, but you see the standard deviation is different. So apparently the consistency of titration between individuals was was better. There was less variability in how people titrate between patients. And in this study, there was a significant difference between the pain score in standard care and the null-guided group. We think that is because the fentanyl at the end of surgery is retained in the control group, where in the null group there still was some patients who needed some fentanyl, and that eventually led to a better pain score. For other monitors like the analgesia nociception index, there are several studies and they were combined in a meta-analysis that shows a slight reduction capacity in opioids. ANI correlates with the postoperative pain score, so there was an advantageous effect in these studies. And also ANI was able to detect intraoperative hemodynamic and movement events. Surgical PLAT index, same, also a meta-analysis that combines multiple studies, indicates that there is a significant effect on the opioid reduction, and there also is a reduction in emergency time as a consequence. In the same meta-analysis, in this case, there was no effect on the postoperative pain score, but again, that is very depending on how effective the pain therapy was, the strategy for post-op pain in the control group. So there was also not a deleterious effect by titrating according to SPI in this study. My conclusion is that you should use nociception level monitors to reduce or to individualize your remifentanil administration in dose and in timing without deteriorating the postoperative pain score, even sometimes improving it. The goal should not be to use a specific threshold to identify those who will have pain in the future or those who won't, because that's influenced by psychological factors a lot in the post-op phase also, but rather, anyway of the NAN score, anticipate the postoperative pain effectively by a timely administer longer-acting analgesic drug. And the NAN value is rather used to optimize the timing of your perioperative titration. What about the stress response? Does the NAN monitor has an effect there? In the same study we've done with fentanyl sevoflurane, there was no significant difference in the perioperative stress response release, but in the postoperative phase there was about double the stress hormone release of ACTH and cortisol compared to the null-guided group. So there seemed to be an effect on the postoperative stress response. For SPI, there seemed to be a correlation with noxious stimulation and perioperative events, but there was no difference between an SPI group and a control group in the amount of ACTH, cortisol, and epinephrine. There was also, during consciousness, there seemed to be no really correlation between the stress hormone release and the SPI. A bit conflicting data. In this study, multiple monitors were used to titrate remifentanil and propofol and was compared with a control titration clinical practice. In that result, we see a diverse response. If you use PPI, the pupillary pain index, you see that the remifentanil administration was higher compared to control group, whereas the SPI and null decreased the concentrations. And in the stress response, there seemed to be a higher intraoperative cortisol level in the SPI and the null group because of the reduced remifentanil, whereas the PPI and the control group, they have a lower perioperative stress response release. And this is probably because this protocol allowed that the remifentanil administration was stopped from time to time, and that resulted in very low administration rates in some patients, and it's very clear that there's a direct correlation between the amount of remifentanil given and the increase in stress response. So I think you can reduce your remifentanil to a certain level, but don't overdo it, because you need to maintain a lower threshold of analgesia, because these monitors do not predict how they don't anticipate the noxious stimulus. You still need the eyes of and the vigilance of the anesthetist to anticipate on the next noxious stimulus. So on stress response, the relation between humoral stress response is inconsistent, especially during surgery it's not clear, but post-op there might be a beneficially effect. My common sense would advocate that you don't reduce your opioids to zero, keep an eye on the patient and maintain a lower threshold and anticipate the next phase of surgery. Now, are there some informations on chronic pain? Two small things. One is that in one of the studies, its secondary outcome measure was the chronic pain incidence between an anesthesia nociception index guided group and control group, and there was a 12% reduction in pain mentioning after 3 months of surgery compared to standard group. And in this abstract, there was a correlation between the area under the curve of the null above 20 and above 30 during surgery and the occurrence of pain at day 1 during mobilization or day 3 or 3 months. So this was with knee replacement surgery and the former one was for gynecological surgery. So in conclusion, you can reduce opioid administration and excessive amounts of opioids with the non-monitors, but it's not the holy grail to go as low as possible. It helps you to improve the timing and the dose of your analgesic drug administration, and it improves consistency in your management. In the recovery, this will not result in higher pain scores, so the reduction in remifentanil is not accompanied with an increase in pain, and the stress hormone release after surgery might be affected in a good sense, but the results are rather inconsistent, especially also during surgery. And then for long term, there are some promising observations in some studies that indicate a positive effect on 3 months pain scores. Having said that, I thank you for your attention.